Welcome everyone. Let me present my PhD work with the title Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy and Adherence. My name is Anita Pfeffer. I'm a medical doctor and a PhD student at the Pediatric Center Semmelweis University. My vision is to improve the survival and life quality of oncological patients. In order to achieve this, my mission is to identify the least harmful and most effective therapeutical opportunities for these patients. Currently, I have two ongoing projects. In my first project, I investigate the effectiveness and safety of available therapies in adrenocortical carcinoma, and in my second project, I focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivals. Let me tell you some details about my first project with the title Comparing the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma. We are working on a systematic review and meta-analysis in this topic. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available, especially in childhood and in advanced stages. That's the reason why my aim is to investigate the effectiveness and safety of additional therapeutical modalities in this disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical modality contributes to recurrence-free survival and overall survival. My clinical question is, which adjuvant therapeutic modality provides the best survival and lowest number of side effects? We used the PICO framework. We investigated patients with adrenocortical carcinoma and compared mortality and side effects between those who received additional adjuvant therapy to those who did not receive it. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increased survival rate in adrenocortical carcinoma. We conducted our systematic search in the middle of November 2023, and we updated our search in the middle of October 2024. We found more than 19,000 hits, and after the whole selection process, we had 86 eligible full texts for analysis. Let me show you my most important results. On the first forest plot, we investigated adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without mitotan treatment. Hazard ratio is a measure used in survival analysis to quantify the relative risk of an event occurring in one group compared to another over time. It represents the ratio of the hazard rates between the two groups. We included 60 retrospective cohort studies in our analysis, and we divided them into 3 different subgroups based on the stage of the disease. We investigated separately the overall survival in patients with stage 1-4, in patients with stage 1-3, and in patients with stage 4 disease. The importance of this subgroup analysis is that the effectiveness of the treatment can be highly influenced by the extent of the disease. The measure of effect is adjusted hazard ratio. If the hazard ratio is more than 1, so it is on the right side of the level of no effect, it means that the intervention group has higher risk for death compared to the control group. If the hazard ratio is less than 1, so it is on the left side of the level of no effect, it indicates that the intervention, so in that case, additional mitotan treatment reduces the risk of mortality. The overall hazard ratio is 0.54, which means that additional mitotan treatment reduces the risk of death by 46%. This result is clinically relevant and statistically significant. We got similar results based on our subgroup analysis, and we found that additional mitotan treatment significantly reduces the risk of death in patients with stage 1-4 and in patients with stage 1-3 adrenocortical carcinoma. On the second forest plot, we examined the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without radiotherapy. The overall hazard ratio is 0.66, which means that additional radiotherapy reduces the risk of death by 34%. This result is clinically relevant, but not statistically significant. However, we found that additional radiotherapy significantly reduces the risk of death in patients with localized adrenocortical carcinoma. On the third forest plot, we examined the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without cytotoxic chemotherapy. The overall hazard ratio is 0.61, which shows that cytotoxic chemotherapy seems to reduce the risk of death. However, there is a wide confidence interval caused by the third outlier study, which must be taken into consideration when discussing this result. The most important strengths of our analysis are the stage-based subgroup analysis, the high number of participants, and the complex and comprehensive analysis. To highlight limitations, most of the included studies are non-randomized studies, there is a high heterogeneity of patient characteristics, and there is missing adjustment for important variables in some studies. In conclusion, we can say that mitotan treatment and radiotherapy prolong survival in both localized and advanced stages of adrenocortical carcinoma. The clinical implication of our finding is that both mitotan and radiotherapy improve oncological outcomes in both localized and advanced stages of this disease, so their routine use should be considered in the clinical practice. Further research is needed to evaluate the efficacy of cytotoxic chemotherapy, analyze the effectiveness of the different treatment approaches across different stages and among pediatric patients, and more RCTs are needed to minimize the selection bias. I finished my manuscript and we submitted our paper at the end of September to Clinical Medicine, which is a D1 journal. We received a revision request at the end of November and we submitted our revised manuscript at the end of December. Now we are waiting for the hopefully positive feedback. Let's move on to my second project with the title Efficacy and Safety of Growth Hormone Therapy for Pediatric Brain Tumor Survivors based on real-world data. We are planning to do an international survey in this topic. Brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. However, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common is growth hormone deficiency, which can be caused by the hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed international guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency in the clinical practice and investigate the effect of the different treatment approaches for safety and efficacy. My clinical question is, how does the different management of growth hormone replacement influence the growth and the risk of recurrences and secondary malignancies in pediatric brain tumor survivors? I would like to use the PICO framework, in which population will be pediatric brain tumor survivors, intervention and comparison, the different management of growth hormone replacement, primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement, according to the international guidelines, provides the best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. Here you can see the progress of my second project. We prepared the planned questionnaire, database, and protocol, and we would like to discuss it with external experts next week. To summarize, as I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the least harmful and most effective therapeutical opportunities for them. With these two researches, I would like to contribute to achieving this. I would like to finish my presentation with the words of Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your attention.
You have also some data about other deficiencies, not just growth hormone deficiency, and about the clinical practice, how to supplement, or you are just focusing on growth hormone?
Thank you for your question. In the case of brain tumor survivors, yes, the most common side effects are the endocrine deficiencies, such as central hypothyroidism or central diabetes insipidus, etc. So yes, these are the most common.
You are just focusing on that one?
Yes, we would like to focus on this side effect. but we would like to investigate the prevalence of the other endocrine side effects as well, but we would like to examine the safety of this growth hormone replacement in this patient population.
Congratulations. So have you seen any data in the literature which shows why the growth hormone replacement is missing in many patients? Is it because the doctor's afraid of it? Is it because the parents are afraid of it, or something else?
Thank you for your question. It's a very interesting question. I think so that the endocrinologists have afraid to start this treatment, and before starting growth hormone replacement, they always have to discuss it with the parents, and in a lot of cases, the parents are afraid of the potential side effects such as tumor recurrence, and that's why they don't want to start this treatment.